Okay. Good morning, everyone. I'm Dr. Mpandaguta. I'm attached to the fetal medicine unit. I'm going to present a rare case of Schizencephaly that we encountered in the unit a few weeks ago. So I'm presenting Miss FG. She is 28 years old, third pregnancy with 2 children at home. She was at 39 plus 2 weeks at the time of presentation by a second trimester the dating was done by a second trimester ultrasound scan. So she was referred to the fetal medicine unit for ventriculomegaly, and she didn't have a torture screen done or a combined screening test done in the first trimester. She did not have a fetal anomaly scan done in the second trimester. In her current pregnancy, she was booked at 29 weeks gestation, at 26 weeks gestation, and she had 4 ANC visits, and she was HIV and RPR negative at the time of booking, and there was no history of a febrile illness during her pregnancy. So this was a third pregnancy, successfully at term with no complications. Chronic illnesses, and she was not on any medications. And in her social history, she was not taking any alcohol or smoking. She was not using any recreational drugs. And she stayed in Mufakose with her husband and her children, and she was a housewife, and the husband is a builder, and they were not on medical aid. On her investigations, she only had a full blood count. It showed a normal white cell count of 8.8, an HB of 11.7, an MCV of 91, and a platelet of 144. On the ultrasound scan findings that were done at the fetal defects clinic, we noted a single intrauterine fetus who was in cephalic presentation with a birth weight of with an estimated fetal weight of 3,345 grams. Of note was that there was bilateral ventriculomegaly, with the right being 22.4 millimeters and the left being 19.6 millimeters. And there was communication between the arachnoid space and the ventricular space. And according to these findings, the diagnosis was a neuronal migration disorder, which was Schizencephaly. The couple was counseled on the findings, and the plan was to do a multidisciplinary meeting with the neurosurgeons, the pediatricians, and the fetal medicine units for further management. So on the ultrasound scan findings, this is one of the images which showed, can you see my pointer? There was ventriculomegaly on one side, and the other side also had ventriculomegaly. But of note was that it was now communicating with the arachnoid space. On the second image, it was also just showing the ventriculomegaly and this communication, which continued into the arachnoid. And in the last image, as the scanning was continuing, we saw that the defect was even larger on the right side. So this woman was counseled on the ultrasound scan findings, and the torture screen was ordered. And the management options which were available were expectant or termination of pregnancy. Unfortunately, this patient then went into labor before the multidisciplinary discussion and delivered a baby boy with a birth weight of 3,100 grams at home. This baby cried at birth, and the delivery was assisted by the neighbor. They then presented to the nearest clinic, who quickly referred her to Salim Mugabe Hospital. And when she got to Salim Mugabe Hospital, the pediatric SRMO examined the baby and told her that it was just an enlarged fontanelle, and planned to send her home the next day and book her for a transfontanelle ultrasound scan a week post-delivery. So of concern was that this SRMO, though they were showed all these documentations and these scans, decided to downplay the diagnosis that had been given. What would have been recommended would be to flag this baby as a potential baby with developmental delay. I'm not sure if there are still any red stickers, but to also flag the notes and book this baby for the neurology clinic. I'm not sure if there are any questions at this point in time on the history. So if there are no questions, I can move on to the discussion. So Schizencephaly is a rare neuronal migration disorder, which is characterized by unilateral or bilateral fissures between the ventricular system and the subarachnoid space, which was shown. Sorry?
Maybe I missed it in your presentation. After the baby was sent home, what happened?
So this baby was delivered yesterday in the afternoon at home. So they went to Sally Mugabe and they were seen in admissions by the SRMO. So when I called the mother to follow up, she told me what the SRMO had told her. And so currently they are in the ward waiting to go home this morning.
Okay, have you managed to institute the correct management or to discuss the proper management with the SRMO or the registrar from pediatrics?
I currently had not talked to them as I was waiting to complete this meeting first. I hope I won't be late, or I could then call them after the meeting and discuss with them.
Okay, but what was the discussion on the outcomes?
Unfortunately, the MDT meeting was not done. It ended up being postponed because the teams that were involved in the meeting did not find time to come to the meeting yesterday. But from what we had discussed with the discussion was that this diagnosis is associated with severe mental handicap, developmental delay, and in some cases, even intractable seizures. The parents themselves were willing to go for a termination, but that could not be offered until an MDT had been done.
Okay, thank you.
Are there any other questions or comments before I proceed?
Good morning, Dr. Mpandaguta. I'm sorry,
Good
I think
morning,
my network dropped. I didn't hear. Did you do the corrective measures? Did you try to talk to a senior? Because in SRM, it's unfortunate that an SRM in pediatrics finds it comfortable to do these kind of things, which I think reflects probably on the supervision component. Did you try to talk to somebody senior?
Unfortunately, I had not managed to talk to anyone senior, but after the meeting, I could talk to one of their senior registrars or their junior registrars. I do have their contacts.
We had requested that we invite a neonatologist. Did you manage to invite anyone?
Yes, I had invited them, but I think maybe they're not in the meeting.
Because I think for the teammate Sally, currently one person should go to the neonatology unit and ask that patient should not go home until she has been assessed by a consultant, because I think the management plan is wrong.
I do agree.
Think is SRMO aware that there is a bigger problem than what they are saying, dilated fontanelle, or the SRMO didn't put it already?
In this case, I don't think they were aware, but I did talk to the patient and she did explain everything and showed them the ultrasound scans. The clinic quickly referred them because they'd seen the ultrasound scans and the diagnosis that had been given.
It's okay. I think corrective measures should be done this morning before the patient is wrongly discharged without a care plan. Thank you.
Thank you. I agree. May I proceed with the discussion?
Are there any other questions or contributions? And I think in terms of the red stickers, we'll start to use them next week, like what you highlighted. Thank you. If there are no other questions or contribution, I think you can proceed.
Okay, thank you. So Schizencephaly is a rare neuronal migration disorder characterized by unilateral or bilateral fissures between the ventricular system and the subarachnoid space. And this is extremely rare and occurs in 1 in 100,000 birds. Of note is that there are two types, which is open lip, if the cleft folds are not juxtaposed and there's communication between the ventricular system and the subarachnoid space, like in the patient that we have. Or it can be closed lip if the wall is split and partially fused. There's also what is called a cleft labial malformation, which can be defined by the presence of CSF fissures in the cerebral hemispheres that extend from the cortical surface to the ventricles. In 70% of the cases, the lesions are in the parietal lobe, and in 50 to 90% of the cases, there are other associated brain abnormalities, including hyaline septal hypoplasia, optic septal dysplasia, and severe ventricular enlargement. The exact etiology is not clearly understood, but there are some proposed factors that have been said to contribute to the formation of neuronal migration disorders. And these include exposure to teratogenic agents like alcohol, warfarin, recreational drugs like cocaine, or prenatal infections like CMV, Zika virus, toxoplasmosis, and parvovirus. There's also been proposed the theory that an hypoxic episode in the 8th week of gestation can contribute to these neuronal migration disorders, and also genetic factors and stroke in utero. So in the theories involved, I've partially explained them in the slide before. The first theory, which talks about in utero exposure to CMV or any other infection that will result in an inflammatory process, which leads to mid or cerebral artery stroke, or environmental factors like drugs or alcohol abuse, which may contribute to maldevelopment of the brain. And the third theory involves genetic factors, which can also be said to contribute to the development of Schizencephaly with the EMX2 gene and the COL4A1 mutations. So investigations include a detailed ultrasound, which includes neurosonography. A fetal brain MRI can help to distinguish between Schizencephaly, which is a neuronal migration disorder, and foraminencephaly, which is a vascular injury. A fetal MRI can also help detect pyrogyrus, which is brain overfolding, which is a constant finding in Schizencephaly. And follow-up is with fetal ultrasound, and the care plan may either be expectant care or termination of pregnancy. There are no special things to look out for delivery, but you should offer standard obstetric care. Post-delivery, the aim is to optimize the child's developmental potential and manage symptoms related to the illness. And the pillar is neurorehabilitation, which includes physiotherapy, speech therapy, and language therapy. And if there's hydrocephalus, a ventriculoperitoneal shunt may be required. There's also need to control seizures. So the prognosis of schizencephaly depends on the size and the location of the brain cleft, with open lip having a worse prognosis. And it may, and there is a range of symptoms and signs, which include cognitive deficits, hemiparesis if one side is affected, quadriparesis if both hemispheres are involved. There's also varying developmental delay and even intractable epilepsy. And if there's involvement of the optic septum, they may have blindness. But according to research, there is no increased risk of recurrence in the next pregnancy. So there are a few cases that I did come across. I only picked two just to highlight how these babies may then present after birth. The first case is an 18-month-old male from Nigeria who was referred for MRI with recurrent generalized tonic-clonic seizures, which they were struggling to control on sodium valproate. This pregnancy had been complicated by malaria at 6 months pregnancy and had been treated in hospital. This baby was then delivered at term with no postnatal complications. And on examination, the child had no dysmorphism, but had global developmental delay and spasticity in the left upper and lower limbs. He had normal growth, and a working diagnosis had then been made of cerebral palsy had then been made. But on MRI, they then noted a wide CSF-filled gray matter-lined cleft extending to the subarachnoid space, communicating with the ipsilateral ventricle. That's when they made the diagnosis of schizencephaly. In the second case, this was in America, a 2-year-old toddler who had presented at the pediatric clinic with hemiparesis of the right side and was unable to speak since infancy, but had no history of seizures, trauma, abnormal urine, or unusual urine color. She had slight delay in gross motor skills, and CNS exam had normal cranial nerves and right-sided spasticity of both upper and lower limbs. The mother had delivered her at 20 years and no ultrasound scan had been done during the pregnancy. The brain MRI then showed a right frontoparietal cleft connecting the subarachnoid space to the ventricles and had an absent septum pellucidum and corpus callosum. The diagnosis was consistent with an open lip schizencephaly, and her treatment was physiotherapy and follow-up in a neurology clinic. So these cases were just to highlight the different presentations the different things that these babies may then present with post-delivery. Thank you.
Thank you, Dr. Mpandaguta, for the detailed presentation. I shall leave this time to the floor for any questions or contribution, and then Dr. Munya, you can start sharing your screen. So you can stop sharing, Dr. Any questions or contribution?
Okay.
Yes,
My own contribution. Yeah. My
It's
own
okay.
contribution is we're going to follow up the patients soon after the meeting, and try to also involve the pediatrician and to properly document in the patient's notes on the risk of neurological impairment, the seizure risk, the developmental delay, the hydrocephalus, and the long-term disability, and also try to reconcile the mother. So that's on our own contribution. Then on the red stickers, I think we also again try to find out where we are now from Sister Cham. It's over to you, Dr. Verenga.
Thank you, Chamba. I wanted to ask Dr. Mpandaguta, what are your other differentials, Dr. Mpandaguta? I was expecting that you were going to give differentials when you were doing the diagnosis.
Okay.
What else could it be besides Schizencephaly?
Besides Schizencephaly, it could be porencephaly, but this one would then be distinguished from Schizencephaly because the brain cyst would be lined by gray matter as opposed to Schizencephaly, which would be lined by gray matter. The other differential would have been holoprosencephaly and also an arachnoid cyst.
Are there another question? I don't know on the counseling risk, since we don't know whether it's a genetic cause or not, you might also need to counsel a that is less than 1%, but if there's genetic risk, then it's about 25%. If there are no other contributions from the floor, I don't see any hand that's up. I think Dr. Munya can start presenting.